This video is for educational purposes only. The information provided is intended to enhance your understanding, should not be used as a substitute for professional medical advice, diagnosis, or treatment. In this video you will learn the Glasgow Coma Scale under the subheadings, Purpose and Scope, Development and Background, Scale Structure, Psychometric Properties, Scoring and Interpretation, Administration, Norms and Standardization, Utility and Practicality, Cultural Sensitivity, Clinical and Research Applications, Limitations and Criticisms, Updates and Revisions. Purpose and Scope. Objective. The Glasgow Coma Scale, GCS, is designed to assess the level of consciousness in patients who have experienced traumatic brain injury, TBI, acute stroke patients, or critical care patients. It helps determine the severity of the injury and monitor changes over time. Target population. The GCS is used for patients of all ages who have sustained head injuries or are in a state of altered consciousness, including those in emergency, intensive care, and trauma settings. Development and background. History. The GCS was developed in 1974 by Graham Teasdale and Brian Jennett, neurosurgeons at the University of Glasgow. Development process. The scale was created based on clinical observations and the need for a simple, reliable method to assess consciousness levels. It has been widely validated through clinical studies and peer-reviewed research. Scale structure, format. The GCS is composed of 3 components: items, eye-opening. 4 items: spontaneous, to sound, to pressure, none, verbal response. 5 items: oriented, confused, inappropriate words, incomprehensible sounds, none, motor response. 6 items: obeys commands, localizes pain, withdraws from pain, abnormal flexion, abnormal extension, none, dimensions. The GCS assesses 3 dimensions of responsiveness: eye, verbal, and motor responses. Psychometric properties, reliability, validity. The GCS has been extensively studied and validated. Studies have shown it to have good inter-rater reliability and validity as a predictor of patient outcomes following traumatic brain injury, TBI. The scale's reliability is high, with kappa values typically above 0.8, indicating substantial agreement between different raters. Scoring and interpretation. Scoring system. The total GCS score ranges from 3 to 15, calculated by summing the scores from each component, EVM. Interpretation. Severe brain injury, GCS score 3 to 8, moderate brain injury, GCS score 9 to 12, mild brain injury, GCS score 13 to 15. Administration method. The GCS is administered through direct patient observation and interaction by healthcare professionals. Time requirement. It typically takes a few minutes to administer the GCS. Training. Basic training is required for accurate assessment, ensuring consistency and reliability. Administration, eye-opening, E, 4 points. Remember, as some voices provide nothing, that is, spontaneous, voice, pain, none. For spontaneous, eyes open on their own. Stimulus, no stimulus needed. Response, eyes are open. 3. To speech, eyes open when spoken to. Stimulus, calling the patient's name. Response, eyes open in response to voice. 2. To pain, eyes open in response to a painful stimulus. Stimulus, pinching the trapezius muscle. Response, eyes open. 1. No response, eyes do not open. Stimulus, any stimulus. Response, no eye opening. Verbal response, V, 5 points. Remember, as our country is in need, that is, oriented, confused, inappropriate, incomprehensible, none. 5. Oriented, patient responds coherently and appropriately. Stimulus, asking questions like, what is your name? Where are you? Response, correct answers. 4. Confused, patient responds coherently but with disorientation. Stimulus, asking similar questions. Response, incorrect answers but coherent speech. 3. Inappropriate words, speech is inappropriate or random. Stimulus, asking basic questions. Response, incoherent speech, not related to questions. 2. Incomprehensible sounds, moaning or groaning. Stimulus, speaking to the patient. Response, moans or unintelligible sounds. 1. No response, no verbal response. Stimulus, speaking or painful stimulus. Response, no verbal sound. Motor response, M, 6 points. Remember as, only lazy women find excuses Nancy, that is, obeys, localizes, withdraws, flexion, extension, none. 6. Obeys commands, patient follows simple commands. Stimulus, asking the patient to move a limb. Response, executes the command. 5. Localizes pain, attempts to move away from a painful stimulus. Stimulus, applying a painful stimulus. Response, moves hand towards the source of pain. 4. Withdraws from pain, general withdrawal from painful stimulus. Stimulus, applying a painful stimulus. Response, pulls limb away. 3. Flexion to pain, decorticate response, abnormal flexion. Stimulus, applying a painful stimulus. Response, flexion of limbs in a stereotyped manner. 2. Extension to pain, decerebrate response, abnormal extension. Stimulus, applying a painful stimulus. Response, extension of limbs in a stereotyped manner. 1. No response, no motor response. Stimulus, any stimulus. Response, no movement. Quick summary. 1. Assess eye opening, E. Observe if the patient opens their eyes spontaneously. If not, call their name loudly. If no response, apply a painful stimulus, pinching the trapezius. 2. Assess verbal response, V. Ask the patient simple questions. Their name, location. Listen to their responses for coherence and appropriateness. Note if they make any sounds or remain silent. 3. Assess motor response, M. Ask the patient to perform a simple task. Squeeze your fingers. If unresponsive to commands, apply a painful stimulus and observe their reaction. Note any purposeful movement, withdrawal, or abnormal posturing. 4. Calculate total score. Sum the scores from each of the 3 components, E, V, M. Norms and standardization, normative data. Extensive normative data are available for different patient populations, aiding in the interpretation of scores across various contexts. Standardization process. The GCS has been standardized through numerous clinical studies and is embedded in clinical practice guidelines worldwide. Utility and practicality, ease of use. The GCS is simple to use, with clear criteria for each response category. Accessibility. The scale is freely available and widely used in clinical settings. Languages. The GCS has been translated into multiple languages, enhancing its global applicability. Like English, Arabic, Bahasa, Bangla, Bosnian, Catalan, Chinese, Danish, Dutch, French, Gaelic, German, Greek, Gujarati, Hindi, Hungarian, Indonesian, Italian, Japanese, Kannada, Korean, Latvian, Malay, Marathi, Nepali. Cultural sensitivity, cultural adaptation. While the GCS is generally applicable across cultures, minor adaptations may be necessary to account for language differences in the verbal response component. Cross-cultural validity. Studies support the validity of the GCS in diverse cultural settings, though specific cultural nuances should be considered. Clinical and research applications. Clinical utility. The GCS is essential in emergency medicine, neurology, and intensive care for assessing patient status, guiding treatment decisions, and monitoring recovery. Research utility. The GCS is a standard measure in TBA research, providing a consistent metric for evaluating injury severity and treatment outcomes. Limitations and criticisms. Limitations. The GCS may be less reliable in intubated patients, due to the verbal component, and those under sedation. It also has limited sensitivity for detecting subtle changes in consciousness. Criticisms. Some critics argue that the GCS is too simplistic and fails to account for more nuanced aspects of brain function. Updates and revisions. Version history. Since its introduction, the GCS has remained largely unchanged, with minor modifications to improve clarity and reliability. Revisions. Recent efforts include the development of the Glasgow Coma Scale pupil, GCSP, which integrates pupillary response for better prognostic accuracy.